Good morning, everyone. Today, we'll be discussing some key topics related to the lumbosacral spine, including sacroiliac joint instability, claudication, and the differential diagnosis process. By the end of this session, you should be able to effectively ask historical questions pertaining to lumbar spine conditions, recognize the presentation of intermittent vasculogenic claudication, understand when to suspect sacroiliac joint instability, and consider the wide range of potential pain generators in the lumbar region. Let's start by reviewing some essential historical questions to ask when evaluating lumbar spine conditions. First, inquire about any radiating pain, numbness, or tingling sensations throughout the body, as these can be indicators of nerve involvement. Additionally, ask about any instances of tripping, stumbling, or perceived clicking or popping sensations in the lumbosacral region, as these may suggest instability or joint translation. For patients with suspected sacroiliac joint involvement, it's crucial to ask about any history of trauma, as most cases of sacroiliac joint instability stem from some form of injury. Inquire about previous treatments, such as chiropractic care or manipulation, and whether these interventions provided any relief, even if temporary. Other key historical questions include whether the patient experiences an increase in symptoms when walking uphill or on ramps, and whether the pain is worse in the morning upon waking or in the evening. Be sure to ask about any urinary retention or saddle paresthesia, as these can indicate more serious neurological involvement. It's also essential to determine if the pain is unrelenting regardless of position, or if there are any recent infections or fevers, as these can suggest underlying inflammatory processes. Moving on to the physical examination components, a thorough evaluation should include reflex testing, motor evaluation, sensory evaluation, provocative tests such as nerve traction tests, and mechanical tests, and an assessment of range of motion, if possible. Regarding reflex testing, it's crucial to emphasize that you should always perform a comprehensive examination of both upper and lower extremity deep tendon reflexes, including the Hoffman's reflex and ankle clonus. Never let anyone convince you that skipping reflex testing is acceptable. It's an essential component of the neurological evaluation. While the inability to render a definitive diagnosis can be frustrating, it's important to avoid prematurely labeling a patient as a malingerer. There may be complex underlying factors at play, and a thorough examination and thoughtful differential diagnosis process are necessary before making such a determination. Let's now discuss the sacroiliac joint in more detail. Potential conditions involving this joint include sprains, hypomobility, instability, and ankylosing spondylitis. In cases of sacroiliac joint sprain, the typical presentation involves an onset following prolonged bending, standing from a bent position, or lifting an object, similar to disc pathology or a sprain/strain of the lumbar spine itself. The pain is initially sharp, and patients can often point to the sacroiliac joint as the primary site of discomfort. While the pain from a sacroiliac joint sprain may radiate, it typically does not exhibit Valsalva-like characteristics, and reflexes, sensory function, and lower extremity motor strength are usually unaffected. However, testing more proximal muscles, like the gluteus maximus or iliopsoas, may be uncomfortable due to the sacroiliac joint sprain and associated pain. In cases of sacroiliac joint hypomobility, you may be able to palpate decreased mobility at the joint, and there may also be a noticeable leg length discrepancy. Provocative tests targeting the sacroiliac joint will likely exacerbate the patient's pain, and differentiating sacroiliac joint pain from L5S1 facet pain can be challenging due to their anatomical proximity and similar aggravating factors. You've previously learned about ankylosing spondylitis, a condition that can affect the sacroiliac joints. In these cases, MRI imaging may reveal inflammation within the joints, and you should consider ordering the HLA-B27 lab test and referring the patient to a rheumatologist for co-management. Interestingly, our institution is currently involved in a multi-center investigation aimed at early detection of ankylosing spondylitis, based on 5 key questions. The responses to these questions will be compared to MRI findings of the sacroiliac joints and HLA-B27 lab results to evaluate their diagnostic utility. For patients with suspected ankylosing spondylitis, you may also consider referring them to an Ayurvedic practitioner. However, it's advisable to allow the patient, and their parents if applicable, to be fully informed by both the rheumatologist and the Ayurvedic practitioner, ensuring a comprehensive understanding of the condition and available treatment options. Moving on to sacroiliac joint instability, this condition typically presents with severe pain following trauma, often due to tearing of the sacroiliac ligaments. The clinical examination may point to involvement of the lower lumbosacral region, and patients often report a sensation of the sacroiliac joint slipping or translating. Interestingly, imaging findings in cases of sacroiliac joint instability may appear normal or insignificant, and patients often fail to improve with conservative care. Manipulation of the sacroiliac joint may provide only short-lived relief, with the joint becoming unstable again within minutes, and the patient reporting a sensation of the joint slipping out once more. During the physical examination, you may notice marked hypermobility of the sacroiliac joint on the affected side, and you may feel excessive motion during manipulation attempts. Patients often describe a sensation of subluxation or nausea accompanying the joint translation. While imaging may not always be conclusive, X-rays can sometimes provide valuable information. Consider obtaining standing AP pelvis views, as well as one-leg weight-bearing AP pelvis images to compare bilaterally. Movement at the pubic symphysis may indicate excessive sacroiliac joint motion. In terms of treatment, prolotherapy has shown great outcomes for sacroiliac joint instability, and some practitioners have suggested the use of platelet-rich plasma, PRP, therapy as well. In summary, while cases of true sacroiliac joint instability are relatively rare, they are characterized by a history of trauma, persistent low back pain that fails to resolve, ongoing sensations of joint translation, failure to respond to conservative care, and markedly hypermobile sacroiliac joints on examination, often with normal or insignificant imaging findings. Let's now discuss piriformis syndrome, a condition that is often excessively diagnosed within our profession. It's important to note that piriformis syndrome is an extremely rare occurrence, believed to be caused by compression of the sciatic nerve by the piriformis muscle. Patients with piriformis syndrome typically complain of buttock and posterior thigh pain, which is thought to arise from the compression of the sciatic nerve by the piriformis muscle. In some anatomical variations, the sciatic nerve may even perforate through the piriformis muscle. Interestingly, patients with piriformis syndrome often present with radicular pain without accompanying low back pain. Straight leg raise testing may or may not reproduce the symptoms, and reflexes and motor function are usually normal. However, the piriformis muscle itself is often exquisitely tender to palpation, and may reproduce the patient's symptoms upon examination. While electromyography, EMG, studies may occasionally reveal abnormalities in the piriformis and distal muscles, it's important to recognize that a tender piriformis muscle alone does not confirm a diagnosis of piriformis syndrome. This condition is relatively uncommon, but when present, it is most often seen in runners and tennis players. However, you must determine whether the tenderness is simply due to a taut, overworked piriformis muscle or if true nerve compression is occurring. Finally, let's discuss intermittent vasculogenic claudication. If a patient with this condition presents to your office, they will likely complain of lower extremity symptoms that are exacerbated by activity, typically walking. One key characteristic of vasculogenic claudication is that the symptoms often present after a certain amount of time or distance, such as the patient stating "I can only walk 1 block" or "I can only walk for 6 minutes." This is because the pain is occurring due to ischemia from arterial insufficiency, likely caused by stenosis or obstruction. Typically, the symptoms of vasculogenic claudication improve with rest, even after a short period of just 1 to 2 minutes of sitting or standing still. However, the symptoms will return after the same amount of time or distance, which can be incredibly frustrating for patients. Before considering a vascular etiology, it's crucial to perform a comprehensive lumbar workup first. Why? Because common diseases occur more commonly. If the lumbar evaluation fails to identify the underlying pathology, then you should proceed with a vascular workup. You may wonder if swelling would be expected in cases of intermittent vasculogenic claudication. The answer is no, because this is an ischemic process rather than a venous condition like deep vein thrombosis, DVT. With vasculogenic claudication, you would not expect to find significant swelling. So how would you perform a clinical examination for intermittent vasculogenic claudication? First, the patient's history should strongly suggest this diagnosis. During the physical exam, it's essential to palpate and assess the pedal pulses, including the dorsalis pedis, posterior tibial, popliteal, and femoral arteries. In addition to pulse evaluation, you should assess capillary refill time, which should be less than 2 seconds in normal, healthy individuals. Also, palpate the skin temperature, as it may feel cooler than normal in cases of ischemia. If vasculogenic claudication is suspected based on the history and physical examination findings, the next step is typically to order a Doppler ultrasound. Importantly, this study should be performed not just on the popliteal artery and distal vessels but extending up to the common iliac artery to comprehensively evaluate the arterial system. If the Doppler ultrasound reveals evidence of arterial stenosis, the patient should be referred to either an interventional vascular radiologist or a vascular surgeon for further management and potential revascularization procedures.